Welcome to this last session of the Global Health Academy, the last panel session, I should say, on global control of COVID-19, what needs to be done. My name is Astrid Börner-Rodorida. I'm a researcher and PhD candidate at the Heidelberg Institute of Global Health. I'm working on HIV and gender and ethical issues. And in my previous life, I was working for an NGO for over 2 decades on access to prevention and treatment issues. I am thrilled to introduce a high-profile panel to you today. It seems the thing is stuck. Can anyone? Yeah, we're moving to the next slide. Thanks. We've got panelists from various parts of the world, highly educated with many achievements, and you will be able to read more about their biographies on the program. I will just give you a short summary here. So I would like to welcome Catherine Kyobutungi. She's the Executive Director of the African Population and Health Research Center in Nairobi, Kenya. She's also the chair of the Job Lange Institute and director of the Consortium for Advanced Research Training in Africa. We've got Sam Piri. He's the programs director of Partners in Hope Malawi and used to be the director of the Lighthouse Trust. He's an implementation scientist and professor at various universities, the College of Medicine, University of Malawi, the School of Medicine at University of North Carolina, and the Department of Global Health at Washington University. Catherine and Sam, welcome to the panel. And Sam, I hear you're on holiday, so thanks for making time for this. Malawi Kanti Mrita, for whom it's very late. I'm not sure if he's already on the panel. He's the director of a Center of Excellence for Non-Communicable Diseases and Nutrition and professor of the Bruck James P. Grant School of Public Health, Bruck University in Bangladesh. He has recently led epidemiological modeling and the assessment of the impact of COVID-19 on the health and well-being of the South Asian population, and I'm sure he will tell us a little bit more about that. Welcome. Then we will have Karl Lauterbach. He has been a member of the German Parliament since 2005 and is the Director of Health Economics and Clinical Epidemiology at the University of Cologne in Germany and the adjunct professor for health policy and management at Harvard University. As you all know, we're in the coalition negotiations at the moment, so we're very grateful that Karl Lauterbach took time to be with us today. Then we have Michael Stolpe. He leads the Global Health Economics at the Kiel Institute for World Economy. He's also the principal investigator in the Leibniz Research Network, Infections in an Urbanizing World, looking at humans, animals, and the environment, and a member of the editorial board of Health Economics Review. And we're also glad to have the WHO present at the panel. Michaela Pfeiffer has been working at the WHO for over 15 years, and she's the Senior Technical Officer for Transformation, Implementation, and Change. She joined the Access to COVID-19 Tools Accelerators Executive Hub in April 2020 when it was set up. And she coordinated the strategic plan for Act A, which has just recently been published. Welcome, everyone. We're glad you can be here. We're looking forward to some good exchanges, and we will build on the previous discussions and plenaries at this conference. I just want to, with a couple of slides, recap some of what we heard over the last 2 days. We see the waves, the COVID infection waves. We're now in the 3rd wave for the Americas and Europe. We see that these are the areas most hit by the pandemic, followed by Southeast Asia. The other 3 regions, Eastern Mediterranean, Western Pacific, and Africa, seem to be not so affected, but that obviously also depends on how many confirmed cases there are. And to confirm cases, one has to test the population, and we see that there is great disparity there. In the average testing per day in low-income countries is 13 for a population of 100,000. In high-income countries, it's 740. think that or similar slides you've seen quite a lot over the last 2 days. We see that 7 billion vaccine doses have been administered worldwide. That sounds very impressive. And if we look at the adult population globally, if every adult had access to the vaccines, we would have administered 1.5 vaccine doses to everyone in the world. But you can see from this map that this is not the case. We have great disparity. In some countries, we've got over 80% of the population vaccinated. And you look at Africa, where you see a lot of countries colored in red, where some countries have not even managed 5% or 10% of the population to be vaccinated. We also see the war-torn regions, Afghanistan, Syria, Yemen, lagging behind, Papua New Guinea, Nicaragua, but also other regions in Eastern Europe and Bangladesh, Myanmar. What we want to do today with the panel is to see where do we stand with control strategies for COVID-19. This will be our first part. Then we'll look at intellectual property and local production of vaccines and therapeutics. And then move on to other control measures, access to diagnostics, personal protective equipment, health systems. And finally, explore solutions together. In view of time, we might have to merge the last two. We will see. You can ask questions anytime in the chat. They will be transferred to us. And I've got a couple of colleagues who will monitor the chat. Lisa Henning, who is a fellow doctoral candidate with a focus on global health policies and systems, and Florian Neuhan, who is a lecturer on global health, human rights, and disease control. So if you ask your questions, it'd be good to address the topic that you are interested in. And for the panelists, since we're doing the panel in English, I hope it's okay if we just use first names as is common. In English panels, we can revert to a more formal address when we speak German. I hope that that's okay. Let me just see who's here. I think we've got a number of our panelists here. Some are still missing, but I hope we'll get there soon. So without further ado, can I start with, no, I think he's not on the panel yet. No, yes. Malay, are you on the panel?
Yes.
Yes, okay, great. I know it's very late for you. It's already in the evening. So Bangladesh started in early 2020 with vaccination, so quite early on, but we see your country was also one of the red-colored countries. Can you tell us a little bit about what the COVID situation is at the moment and what has hampered vaccinating the population? Over to you.
Okay, thanks, Straight. Yeah, we just had a wave, but like at this moment, COVID situation is kind of under control. For example, only 256 cases were detected today, and only 7 people died from COVID today. So that is at this moment. But so far, Bangladesh detected 1.57 million of COVID cases, and there were over 27,000 deaths. So, I mean, if I take a look at the numbers, so in terms of like number of, cases detected, and so Bangladesh is number 30th country in the world in terms of total number of cases detected. But if we take a look at other figures, like what are the number of people detected per million, so Bangladesh stands at number 152nd. So in terms of deaths per million population, Bangladesh is 144th country in the world. But at the same time, this is also true that Bangladesh has not done many cases. So it is like 172nd country in the world in terms of number of cases, number of tests done per million of population. So, I mean, it also may be true that we were unable to, test everyone who had symptoms of COVID. And that can be one of the reasons that like we detected a lower number of cases. And, so that can also be true. In Bangladesh, case detection facilities or laboratory facilities, we have 833 labs all over the country. And with respect to vaccination, you have already mentioned that we are behind, even behind many of the South Asian countries. That is partly because of sheer number of people in our country. We have about 167 million of people, and 118 million of people are over 18 years. And that is the current government target of vaccination. We have a vaccination application, and 59 million people already registered to the application. 42 million people got the first dose, which is 36% of the targeted population. And 29 million people got the second dose, which is about 25% of the targeted population. But that is like behind all, or even Pakistan, India, Sri Lanka.
Can I just ask, what is hampering the rollout of the vaccination? Why do you think it's not maybe progressing as fast?
Okay, so one thing is that like the number of people to be vaccinated. So, like the target is 118 million. At the same time, we suffered from vaccine shortage because Bangladesh government made a memorandum of understanding with Serum Institute India to purchase like initially 30 million doses, but like when there was a spike in India with respect to number of, so India stopped export of vaccine from India. So that initially hampered our vaccination because we solely relied on India at that time. And even like many Bangladeshi people who got the first dose of Covishield vaccine, but could not get the second dose in time because there was a shortage of vaccine supply. Then the government took initiative to, contact other institutes and other vaccine manufacturers in China. And so then Bangladesh started getting vaccines from China, Sinopharm vaccine. And so Sinopharm is actually, and we also got Moderna vaccines and Pfizer vaccines. Some of them are also through this COVAX arrangement. So at this moment, Bangladesh has so far received 94 million of doses of vaccines, and 72 million of them have already been administered. Mm-hmm. So at this moment, things are okay, but like because of the initial shortage of supply, so there was a problem, and that hampered our vaccination coverage a lot. Thank you.
Thank you very much, Malay. We'll explore some of these issues in more detail as we go along. Catherine, can I ask you, Kenya is the country with the 7th highest number of COVID cases in Africa. Can you describe the situation and the measures that the Kenyan government has taken to curb the spread of COVID-19?
Thanks very much for having me, and I'm happy to be here. And as far as Kenya is concerned, we are at the bottom of the fourth wave, four waves. And right now the cases are quite low and the test positivity rate is quite low. But in terms of the total number of cases, it's about 250,000 confirmed cases. But as Astrid, you said in your introduction, chances are that perhaps there's underreporting because of lack of testing and access. So in Kenya, it's much easier to test people if you're in Nairobi, which is the big city. So Nairobi, as a result, contributes the highest proportion of cases and the highest proportion of tests. And usually when there's a peak of cases, they have the highest test positivity rate, but that seems to be more of a function of access to testing than anything else. So as I said, bottom of second wave, fourth wave. So what's been happening is close, open, close, open, close, open. When the wave starts going up, everything comes to a standstill. ICUs get full, and you know, you don't need to see the Ministry of Health cases. You just monitor social media, and people are desperately looking for ICU beds for their patients and their relatives. And then, of course, the numbers sort of match with that. And so schools close, shops close early, curfew. You know, the last wave, there was something called some disease zone, which included Nairobi and the neighboring counties. So you couldn't move out of that zone, but you could move out elsewhere. So that's really what's been happening. And of course, after if you move out of Nairobi, the same problem happens, that the COVID is not as visible as it is elsewhere. So you see fewer people putting on masks, for instance. You see almost non-existent social distancing. So that is what is happening. And of course, now vaccines have come in. So far, Kenya has received 9 million doses. And in total, so based on the Kenyan government's own estimates, they vaccinated 6% of the adult population. But if you look at the World in Data estimates, they've vaccinated about 3% of the total population. And so that is where we are. And Kenya, like many African countries, has a very young population. So if we extend the denominator to include children, you know, like now in the US, they've started from age 5, then the vaccine coverage perhaps is like 1%, because it's a very, very low percentage. And compared to its neighbors, Kenya is doing relatively well. It's somewhere in the middle. Many countries are doing much worse than Kenya in terms of vaccine access. The map that you showed shows less than 20% of African countries, which have less than 20% coverage. I have some numbers which show, if you dig a little bit deeper, only 14 countries have given more than 10% single dose. And only 20 countries have more than 5% fully vaccinated. And then those who have given more than 20% single dose are nine countries. So the rest of the countries are below that, below 5% single dose. Some are 2%, some are 1%. It's just ridiculous, I think. It's the best way to describe it. Yes. So that's what's happening in Kenya.
We'll explore some of the reasons a bit more why, you know, there is so little, you know, there's so little vaccine to go around in the first place. But you also mentioned the young population in Africa, and that's not just in Kenya, that's, you know, all over Africa. So how do people react to this lockdown? And, you know, it's lifted again, then the next lockdown, if they maybe feel they are not so much at risk?
Yes, I think it's interesting when you sort of monitor the trends and public perception about lockdowns. I think early on, not most people understood why lockdowns were necessary, but as time went on, progressively, few people find it acceptable for governments to lock down anything. And part of it, of course, is as the pandemic has evolved, we are wiser. We know we have to live with COVID, so we have to figure out how to navigate around the difficulties and reduce transmission, but then at least have some sense of normalcy. But also on the other hand, I think there are also political forces, because a lot of countries in Africa have had elections during the pandemic. So on one hand, government is trying to say, stay at home, put on a mask. And on the other, they're having campaigns, you know, huge rallies and moving around with unmasked crowds and singing and dancing. So the person whose business has closed is asking, why should I close my business while the government, the minister, the president is busy campaigning and to get elected? And so it's a contradiction in public health messaging, what the government says and what the government does. So over time, people really, really find lockdowns completely unacceptable. And it takes a lot of guts, I think, for the government to institute a lockdown. But it usually comes at a time when I think people can sense that things are bad. And so people are more accepting, but not for too long. And of course, the young people's schools, the disruption in schooling has been very, very disruptive. But Kenya, since the beginning of the year, has attempted at least to have some normalcy in the school calendar. So most kids are going to school. Yeah.
Thank you. Let me turn to Sam. Sam, compared to Kenya, Malawi has fewer cases, but proportionally a higher mortality rate. Could you explain that, and what measures has the Malawi government taken?
Thanks, Astrid, and it is a pleasure to be on this panel discussion. Yes, so Malawi We just completed also the third wave, and trying to see whether the fourth wave will come along, considering that the numbers have gone down. So far, Malawi has had, they've done about 426,000 tests. So this is actually on a 18 million overall population. So far cases detected are about 61,000, and the mortality, actually the death was about 2,300, which was a case fatality rate of about 3.7. As I'm speaking, there are about 1,500 active cases so far. And Malawi can put up several measures. It was slow, and I think, as Catherine has said, it was similarly that we had also elections which were nullified, and then they were had to be rerun. In that case, so it was indeed, when you're talking about lockdowns at the same time, when you're talking about people going for campaigns. So this had an issue, and as we were starting 2021, so that's when we are really, January 2021, that's when we are really hit significantly in this case. And in terms of schools closing and any opening the schools, and so at the same time making sure that people are enforced in terms of use of the masks, social distancing, and make sure that some of the areas on the public places have been moderated. In terms of the vaccine, it was also slow in terms of coming in of the rollout of the vaccine. But otherwise, so far, in terms of the first dose of the AstraZeneca, about 687,000 got this, which actually is about 4% coverage if you look at the general pool of the population, without without taking out the young ones in there. And then about the Johnson & Johnson, about 205, and so the total fully vaccinated, either one dose of Johnson & Johnson or 2 doses of AstraZeneca, in this case are 255,000, which is about 1.4% when you look at the component of the general population. So as I mentioned, there was a delay on the second dose because actually the first dose was in March 2021, where most of the people got the jab, and it was expected that by June, so starting from May, June, then people would get, but there was a delay in the delivery of the second dose of AstraZeneca and also the coming in of Johnson & Johnson. So one of the reasons you asked the question, for example, to Catherine about the hampering, this was really the delay of the doses was with that. The other component of the delay were some misconceptions amongst the general population. It required actually to have like key messaging to the people because of the stories that we're hearing from outside. Most of these, as Catherine mentioned, we're getting this from social media. So negative actually publicity sometimes was coming in, and it was difficult. We did a study, for example, at Partners in Hope to look at acceptance and uptake amongst healthcare workers. We got 82% uptake amongst healthcare workers, which we felt that was really pretty much good. However, we still got some negative responses that people were getting negative key messages coming out from social media. So we said, I think as we roll out the program, this study was able to inform the national program to say that we should be able to put in key messages right up the front whenever we're coming in with a new vaccination. And the other thing was that people were able to hear that this vaccination was already approved within 1 year of development. So there was a question of whether indeed this vaccine was safe amongst all the people. And so that was one other component which people were hesitating. And then later on, people started to come in and have their vaccination, but we still had to make sure that the government putting in the key messages for the general population to come to the facilities to pick up the vaccination. So that's what I would say for now in a moment.
Thank you very much, Sam. And yeah, it shows how, you know, public opinion can obviously also be influenced. And I think we've seen that in various countries that there's a certain hesitancy for at least certain vaccines.
Yes.
Michaela, can I turn to you? COVAX was set up to ensure that all countries have equitable access for their most vulnerable populations, the health workers, the old people, people with comorbidities, or the vulnerable populations. Yet we've seen that the high-income countries prefer to procure the vaccines through bilateral agreement. So we had a mixture of mainly high-income countries wanting to procure bilaterally, and then I guess COVAX was used more as a charity for the poorer countries. That was not how it was intended. How do you assess this parallel structure with multilateral, bilateral agreements for the goal of achieving global equitable access?
Sorry, I just had to take a moment to unmute myself. Okay, so first I should say that I'm not here in the capacity of representing COVAX. Just for the record, to be clear, I am part of the ACT Accelerator Hub, so I can provide some comments in response to your questions, but it's really, if you want more details or if you want to understand a bit more about the COVAX perspective on that, it would really be for them to answer that question. But perhaps could I maybe start with a little bit about the ACT Accelerator, and then I can segue into sort of what is the ACT Accelerator trying to do overall, and then I can segue into that to explain sort of the big pivot that we're going into just now to really focus in on that equity problem that you were discussing. So if you're not well aware already, so the ACT Accelerator was launched in April 2020, right at the beginning of COVID, when the COVID pandemic began, and it was launched at a time with the aim of creating an end-to-end platform or solution from all the way from research to development, all the way to delivery in country, to really bring to bear, to facilitate the rapid development and deployment of medical countermeasures, because at the time we didn't have it. And importantly, it wasn't just about vaccines. It was about vaccines, it was about tests, it was about treatments, and it was also about the supporting environment, in particular, for instance, ensuring that the delivery of those tools would be safe. So personal protective equipment as well. So importantly, the access to COVID-19 tools, or ACT Accelerator, has a broad remit across the full suite of tools. And what was interesting about it when it was first launched, it was the first ever kind of that type of collaboration, because it really brought together a diverse range of stakeholders from the private sector, from the health development community, from government, from civil society, from philanthropy, in what was an unprecedented collaboration, effectively repurposing big parts of the existing system of WHO, of the Global Fund, of Gavi, of many of the partners, UNICEF, the World Bank, involved. And what it was about, as I said, was about accelerating the development of these tools. Now, we've just launched, as you alluded to, Astrid, we just launched the next 12-month plan, and there's an important pivot in that plan, and I'll get to this point in a minute. And the pivot that's reflected in that plan is that at the beginning we were launched to bring the tools to market. Now, the focus of the ACT Accelerator is around closing the equity gap. So that map that you showed, how do we turn that map from red to yellow to green? And so it's really focusing in on those countries that are lagging behind in terms of progressing, in terms of the coverage levels that they need for their national objectives, but also for the global coverage goals that have been set around access to each of these tools. For instance, the 70% coverage for vaccination target by mid of next year. So that's an important part. So now we're focusing in on closing this equity gap. And to your point about some of the issues that we're seeing, and again, they're probably most visible because of the vaccine story, but they also apply across each of the tools. And that is, we're in a situation now where we have a rather complex ecosystem, but we also have market forces coming into play, increasingly influencing the availability and the supply of these products. We have geopolitical interests. We're seeing bartering happening, using vaccine doses or others. This is a complicating factor. We have national trade decisions. We heard that the colleague from Bangladesh was talking about the need to really focus in India and therefore halt the export. So we have these national trade decisions that are affecting supply. So it's a very, and also I think the point that was made by several colleagues about in a way, the tying up of the COVID response into election campaigns. That's another complicating factor, which has meant that the way that we're seeing the application of public health and social measures, in particular stringent measures like closures or lockdowns, being done very inconsistently across different countries and settings. So all of this is adding a lot of complexity to the picture. But as far as COVAX and just to highlight a few points about that, it is important. While it was a lot of these variables have certainly affected its predictability of supply, it has to date played a really crucial role in serving the vaccine needs of its AMC member countries. It's the latest figure is that it has now shipped more than 450 million doses to 144 countries. And as I said, there are many external factors that are influencing COVAX's ability to deliver these. These are things that COVAX doesn't necessarily have full control over. You know, the bilateral deals that are being made, the point that you just made, lack of transparency from the manufacturers. You know, sometimes they'll be prioritizing other countries in the queue. There's a whole effort underway to try to promote dose swapping or delivery schedule swapping, so that if countries are aware of where they are in the queue in terms of when they would expect to get their deliveries, can they swap out those schedules with others so that we can make sure that the available pipeline of supply goes to where it's most needed?
And Michaela, can I just interrupt you there?
Yeah.
You said that the transparency is lacking, you know, in those agreements that COVAX has with the pharmaceutical companies. How do you think that situation could be ameliorated? Like, how could member countries do something, member states put more pressure on the pharmaceutical companies? How do we get more transparency into these COVAX contracts?
Yeah, I mean, I think we have to be mindful that there are some aspects of that which would, and again, I'm probably not the best person to speak to this, so I need to be careful how I say this, but I think there may be some aspects of that are covered within the contractual arrangements themselves. However, that said, what I can say is that there is work underway through the ACT Accelerator Facilitation Council and through the multilateral the multilateral leaders task force, really about that, working through, for instance, the World Trade Organization, working directly with the CEOs, bringing them to try and figure out what is the space for maneuverability in terms of pushing that transparency. The other thing to highlight in this pivot that I mentioned in terms of how the ACT Accelerator is supporting the response going forward is that we have now a set of global targets which were launched in this event that was hosted by Biden in the margins of the UNGA in September. And these global targets provide a huge opportunity to bring a bit more transparency and accountability collectively as to how the world is working towards meeting those coverage goals. ACT A is part of that, but we're anchoring our work within that. And we think that also will create a mechanism for pushing visibility, transparency, and accountability on this agenda.
Thanks a lot, Michaela, and we'll come back to those goals and how we might achieve them, because I think at the moment, reality is still a long way from those ambitious goals, you know. Michael Stolpe, can I turn to you now? Germany has spent billions on COVID-19 aid to companies to, prevent workers from going into unemployment, to help solo employees, artists, money that other countries are probably, jealous or could only dream of, because they don't have the resources. How do you view the COVID-19 measures that the German government has taken from a socio-economic point of view?
Okay, thank you very much for having me and inviting me to this panel. So I'm happy to try to answer this question as best as I can. I think the initial response, of course, was framed in a situation of great uncertainty, right? When the pandemic first broke out, we knew next to nothing about the virus, and therefore these drastic measures that were taken by many rich countries, like comprehensive lockdowns of the economy and large parts of the society, they were very appropriate. And our chancellor made a very good statement at the beginning when she stated that our goal in the government is to save as many lives as possible without overwhelming the healthcare system. And that was a very, very good statement, because it was profoundly ethical, and it also indicated there was this intertemporal dimension to it, right? So we were trying to flatten the curve like other countries did. And so Germany made a huge investment. I, as an economist, view it as an investment that you do whatever it takes to flatten the curve of these virus infections so that you can save as many lives as possible. And I think on that category, on that indicator, we have done well compared to some other rich countries even, because the number of deaths that we suffer relative to our total population is lower than in many other countries. But now we are, of course, not in the best situation. We have neighboring countries. Denmark, for example, has a much higher rate of vaccination in the population. Also, other Western European countries, such as Portugal, Spain, and others have achieved much greater vaccination success than we have. And so in this global pandemic, you cannot assume that a country that did well at the beginning will do very well or best until the very end. You know, fortunes can change. And so we are now in a tricky situation as the winter approaches and a lot more indoor transmission of the virus will come around. And we are also in this situation that our government has been one of the most resistant to the idea of patent waivers for the COVID vaccines. And I'm not a friend of the patent waivers, as we will probably come.
Can I just stop you there for a moment? We'll deal with that in the next round.
But I want to just mention that the risk that has been neglected, the risk that escape mutations that first emerged in other countries, which have had greater difficulty struggling with the pandemic, these escape mutations are also a threat for the vulnerable populations that we have in Germany and other rich countries.
Thank you very much. And with that, I would like to turn to Karl Lauterbach. We just heard, you know, Germany had fairly stringent measures to start with the lockdown. But when we look at what, you know, the response of different countries, we see every country did their own thing. You know, the one had a hard lockdown, the other one hardly a lockdown at all. Even now, Austria is offering PCR tests for free. In Germany, you have to pay for them now. We've learned a lot over the last 2 years about the virus, but in terms of policy and measures, it seems like there's never been a randomized controlled trial of trying out this policy against that policy. So the empirical basis for policies is maybe a little bit weak. And as you are now negotiating, you know, your new coalition government, what do you want to do differently to the present government? How do you want to put your policy, your measures on an empirical, sound basis?
Well, first of all, thank you for the invitation. As you have just pointed out, we are currently in the process of negotiating what we call a coalition contract. And in Germany, coalition contracts work the following way. They more or less describe what, in rough terms, will be the major reforms that the healthcare system can expect to see for the whole period, basically. So therefore, coalition contracts in Germany are very influential, very important, because they are not, let's say, very abstract or loose agreements, but they are very specific. And so that is one of the reasons why I unfortunately cannot stay into this debate too long, because we are negotiating on a daily basis, including today, and I apologize that I cannot, let's say, be in this fascinating debate for too long. Let me come back to what we were discussing before. I think that Germany has done reasonably well in comparison to other countries, because we had a fairly science-based approach. This is at least my view on things. Germany is among the 10 countries with the lowest fatality rate per million inhabitants in a group of 100 countries. So we did reasonably well, but that was the result, as Dr. Stolpe just pointed out, of a very science-based tough lockdown in the first round. and in the second round, a major testing campaign. And when the vaccines were ultimately available, a very ambitious vaccine campaign. Currently, we have run into trouble because we have in Germany traditionally, not only when it comes to COVID vaccines, but when it comes to vaccines quite generally, we have a fairly high resistance in the population against vaccines. We have a very large anti-vax movement, and this includes vaccines against measles, for example, but also other vaccines. And that group is currently making us a lot of problems. And unfortunately, the group is also supported by many public intellectuals. So you have, let's say, a ground-based anti-vaccine movements, but many intellectuals that support this position, and we do not know exactly how to deal with this. The problem, therefore, is currently that we do have, let's say, a sub-average vaccine rate. We have in total, with correction measures, 70% of the adult population is most likely fully vaccinated among those age 18 to 65. And among those age 65 and older, the vaccination rate may be approaching 90%. So the problem is that, let's say, in the mid-age, we lack vaccination coverage. Roughly speaking, 30% in that age range not fully vaccinated or not at all vaccinated. And in the elderly, we have way more vaccinated people, but there the vaccine effectiveness is waning in exactly the same way it was waning in Israel with the data published by, for example, Mark Lipsitch and his group. So we will have to negotiate now what we will do, and this is actually what we are doing. As of today, we have to think about what our strategy here is. Chancellor Merkel is still involved, and I agree with what Dr. Stolpe said, that the fact that we got through the, let's say, through the first and the second round, and also the third round of the pandemic in Germany reasonably well, was to some degree indeed the merit of Merkel. Not only her initial, let's say, speech to the not only of initial speech to the nation, but later on she was very much interested in scientific evidence and was prepared to orient her own decisions according to scientific evidence. And I think that this is something we should simply continue, and I'm also sure we will continue this, but I cannot give more details as of now because we are in the process of negotiations. And I also think we owe a lot to poorer countries, and that we should, let's say, support COVAX to a larger degree. And I think that you will be debating this later on. I will most likely not be able to participate in the discussion at that point, but my own opinion is that the patents should be waived for the poor countries, but this is my personal opinion. I'm fully aware that this is not the official government position, and was also not Merkel's position. And while I was in agreement with Merkel on many issues, I was in disagreement on this particular point. But this is for you to discuss, and this is as much as I can say now. Thank you very much. And maybe I can just follow up, because you mentioned the booster vaccination for the elderly, or, for people with comorbidities, or, the more vulnerable population. We've seen that Israel has done it to a great part of their population, but there is a debate that the WHO has also highlighted, shouldn't we have a moratorium for more booster shots, and make sure that other parts of the world now get access to the vaccines before we go into the third vaccination? What is your view on that? Well, I do think that we will have a hard time to tell our population that a booster vaccine would be necessary, would be helpful, and that we need it in order to prevent further infections and also, let's say, a major disease, that it is necessary, but we won't do it because we give away the vaccines to other countries. I think that this is a very tough position. From an ethical perspective, I can fully understand that this is what possibly we should be doing, but I don't think that this is that this can be taught to the population. I think that the solution here must be that for all vaccines that we buy and use for ourselves, we should buy an equal number of vaccines and give it away to poorer countries. So if Germany, for example, we have by now we have administered 2 million booster vaccinations, meaning double vaccinations, 2 million, roughly speaking, 2 million fully vaccinated booster vaccinations. And there is another, roughly speaking, then 63 million to come. That is the order about which we are speaking. Then we should make available another 63 million vaccinations to poorer countries and administered either through COVAX or administered it through, let's say, CEPI or some other organization, preferably through COVAX, which we have supported a lot. I mean, in terms of, if you look at it from a per capita basis, no country has supported COVAX as much as Germany did. And I think we should go ahead with that addition, and we should, but I think it's a very tough position, may not be a position that the government is able to defend, that we say, well, the boosters are necessary, they are on the market, you will need them, but you should not take them because other countries don't have any vaccines so far. That from a political perspective, I'm not speaking here as a scientist, but here in the round as from a political perspective, this is a very difficult position to defend.
Yeah, and it seems like this is where the solidarity often ends, you know, when other people are put before one's own population. It's difficult to, I guess, transmit that message to one's own population that, yeah, everyone, we're all in the same boat. And yeah. But you mentioned, Jan, and Germany has donated a lot of vaccines already to COVAX, and, you know, is expected to also donate those that are, you know, running out soon. Now we have heard that, you know, in those EU purchasing contracts, that it's not so easy just to donate them, that there is a clause, a veto right for the pharma companies to grant these or to donate those vaccines to another country needs the agreement of the pharma company from whom one has already purchased it. It seems a bit hard to understand, but what is Germany doing about this clause at EU level so that those vaccines don't have to be destroyed, that they can still be put to use?
Well, I have already commented on this previously. I think that this is an unethical part of the contract because it puts an important life-saving vaccine to waste for bureaucratic reasons. That's not acceptable. So while I believe that we cannot tell the German population, age, let's say 65 or 60, that they will not be in a position to buy a vaccine despite the fact that they need it because their protection is waning. I don't think that this is a position we can take. I do think that we can double up that protection and provide a similar amount of vaccines to poorer countries. And within the contracts that are made on an EU level, such a provision, I think, is not acceptable and has to be taken out. I personally believe that, let's say, the way that the vaccines were purchased by the EU and also the way that, let's say, capacity of production was procured by the EU was not exactly what we wanted it to be. may have been suboptimal, and such contract clauses, such contract strings, as a matter of fact, strings attached to the contracts do not appear to be well prepared and do not appear to be defensible.
You mentioned before about the waiver and that you personally support the waiver. Now, you're negotiating a new government, hopefully an SPD-led government. So what is the new position on the waiver when the new government is in place?
We don't have an official position as of now. As I mentioned before, we are in the process of negotiation. And what we agreed upon is that we do not basically report from out of the process. We do not, let's say, give intermediate results. There will also be, let's say, so the negotiations so far have been very confidential and very productive, very good negotiations. I have been in the process of negotiations like that a couple of times before. This is not my first time, but this is the first time that the confidentiality really works, and I do not want to be the counterexample.
That is perfectly understandable. While you're still with us, I would just like to give the audience a chance to ask questions too. We've already moved a little bit into the second topic, which is intellectual property. Local production is another topic, but maybe there's questions from the audience. Can I ask my colleagues if any questions have come in yet?
I've got no questions so far. However, I do have one, because I'd like to know if these pharmaceutical companies could be sued, because, as you said, it's very unethical when I buy a product which is then basically mine because a value exchange has taken place, and then the company says, "Oh no, you still have to ask me if you want to give it away." So is there any way that we can internationally maybe sue these companies with multiple countries? I don't know. Is there?
Well, I should say I'm not a lawyer, but from my understanding, legally these contracts are, unfortunately, I should say, they are binding. If you buy something and it is for your personal use only, that is a kind of contract which is also known in other fields. That is what I understand. Again, I don't know whether this holds in the life-saving situation where the vaccine can save lives elsewhere. So I have no idea whether such a clause, such a, let's say, a string attached to the contract, so such a condition is still, let's say, legally binding in such a situation. I don't know, but from what I hear, it is not such a, let's say, condition is not generally legally impossible, and it is also not that uncommon.
Perhaps I could comment briefly on this question, because as a background, you have to understand the logic behind the trade-related intellectual property agreement that was part of the World Trade Organization Treaty established in 1995. And there, this TRIPS agreement was made in particular with respect to the pharmaceutical industry. The idea was that the pharmaceutical companies that have product under patent protection are protected from parallel trade, the re-import of products that were designated and sold at a relatively low price to poorer countries, so that these poorer countries do not re-import these products into richer countries, and that would undermine the price-setting powers of these patent-protected monopolies. That was the original idea. And because of that, it is also part of these treaties that the German government or other governments of rich countries signed, that they are not allowed to do bilateral international trade with products they have acquired under the TRIPS agreement. I think that's really the background. So if the German government now wanted to sort of resell these products at whatever price, they would violate basic ideas motivating the TRIPS agreement, and that would be inconsistent with the other policies. But as I said before—
Sorry, can I just interrupt here? I don't think that's quite right. The TRIPS agreement, and is in particular the Doha Declaration, permits parallel importing, and Germany does it all the time. When you buy medicines, they usually are imports from Spain, they're imports from Holland. This is perfectly allowed. This is one of the TRIPS flexibilities allowed. So parallel imports are not in, because
only in the European Common Market. I mean, the European Common Market is one country, but we cannot re-import products from African countries.
No, not from, yes, that is true. But, within Africa can do it within, other African countries, yes, they can do a parallel import. That was, anyway, I don't think we need to get into the legalities, but the TRIPS agreement definitely allows parallel imports. So I think that's a slightly, and this is why, because the reason behind it is they've already made their money, the pharma companies, in selling the products. So they've made the money. So whoever has the product can do with it what they want to do within the parameters. One needs to see, are there patents, are there no patents? That plays into it. But I think that's not quite right from the legality. But what I wanted to ask you, Dr. Stolpe, is that 20 years ago, you've already suggested that the Global Fund should buy the patents and then make them available. And so, a fund should be created now, the fund should be slightly changed to what it was then. Now, in 2010, we had the Medicines Patent Pool established, that gradually moved from HIV to incorporating other drugs, and now also deals with COVID-19 medicines and collaborates with the Technology Access Pool. And this Technology Access Pool, for a long while, the pharma companies didn't really put their products into it. But now we've seen just a few days ago that the pharma company MSD has put the drug in development Molnupiravir, I think it's called, into the pool. How do you feel about that? How do you feel about the pool idea? Is this what you had envisaged, or were your ideas 20 years ago slightly different?
My ideas are different. They are based on a path-breaking research paper that was published in the year 1996 or so, 1998, in the Quarterly Journal of Economics by professor of economics at Harvard University, whose name is Michael Kramer, who has been awarded the Nobel Prize subsequently. And he developed a theory of patent buyouts to encourage innovation generally. And that's a different incentive system from what we have in place, but it is built on the patent system. And my proposal is to use it to make vaccines available to all people in this world very rapidly. And that could be done if a global fund such as COVAX, were to acquire the patent rights for the most effective vaccines that have been developed and are still under patent protection. They should acquire the patent rights and then offer free production licenses to any qualified generics or vaccine maker in any country of the global south or around the world, really. That would reduce the cost of producing and delivering vaccines to the marginal costs, which are very low. For example, for the messenger RNA vaccines, they have been estimated at €1 per dose. €1 per dose, that is approximately 1/6 of the price tag that has been paid, according to reports by Oxfam, by the African Union. And the European Union has paid 19.5 euros, 19 euros 50 per dose. So that's a huge profit margin for these companies. And my proposal would involve voluntary sale of the patents. So it entails an auction system, an auction scheme that would be set up by the COVAX fund, would be supported by the rich countries financially. And then the pharmaceutical companies would make a greater profit than they can hope to make if they directly try to sell their vaccines to countries around the world. They would make a greater profit, but the world would still benefit enormously because the vaccines would become available much, much faster and at much lower marginal cost for the countries that want to acquire the vaccines. And this system would, by the way, mimic what we have established in rich countries, namely solidarity-based healthcare system, where the government purchases the vaccine centrally and then distributes, offers for free to everybody who wants to be vaccinated. This is the established system in rich countries, and the pharmaceutical companies can extract monopoly rents on their innovations, but everybody can get access for free, and we should have that for the whole world. The reason why we don't have it is because we have sovereign countries who compete. You know, they compete. We had the advanced purchase commitments that have been mentioned. The advanced purchase commitments were a good idea because they created the market for COVID-19 vaccines at a time when none of the vaccines was successfully developed. So the companies knew there would be a huge market, and they had strong financial incentives to pursue the development of these vaccines to the end. So they made a huge difference, these advanced purchase commitments. Unfortunately, they have a very negative side effects. They created the queue, and now COVAX finds itself at the end of the queue, along with so many poor countries, because these advanced purchase commitments by the rich countries were, of course, the priorities for delivery. And we have another problem in the global scene. That is the fact that the rich countries did not understand that if they order deliveries, they contracted on the deliveries. So Germany and the European Union, Germany, other countries like the UK, the US, they contracted on the delivery of a certain number of vaccines, right? Instead, what they should have done, they should have contracted on the building of capacity to produce vaccines. But they didn't do that. And so the pharmaceutical companies, after they signed the contract for the delivery, they underinvested in the capacity to produce the vaccines, and that led to the delays. You remember early on, we had a big diplomatic row between the European Union on the one hand and the UK government on the other hand, because the Europeans felt the UK, who left the European Union in Brexit, that they were given priority by AstraZeneca, for example, delivering the vaccines to the UK, which had signed the contract earlier and probably paid a higher price for the vaccines. And so these conflicts will go away if we have patent buyouts, so that there will be competition, intense competition in the production of each vaccine. And then it doesn't matter what one firm that happens to hold the patent invests in the capacity. It will no longer matter, but there will be competition in the production for each vaccine, and that would accelerate global vaccine supply.
Okay, I think the idea of the technology access pool is in a way also a one-stop shop. It's like a big voluntary license where the pharmaceutical companies issue the license to the pool, and that then generic firms can be licensees and produce them. Catherine, can I ask you, what difference would a TRIPS waiver make for Kenya, for the local production? Like, do you think Cosmos or other companies in Kenya would produce the COVID-19 medicines if there was a TRIPS waiver?
I think the debate about TRIPS waiver is not standalone. It's accompanied by voluntary technological transfer. But then what Africa is saying is, we don't expect that there are very many African companies ready to start vaccine manufacturing, but there's capacity in other parts of the world. So that is the argument. It's not that if you waive TRIPS, all of a sudden every single country can do vaccines, but there are many countries in other parts of the world, whether they're in Latin America or Asia or wherever it is, that can improve the current supply so that there are vaccines for everyone. So that is the argument, really, because Africa does not have that much capacity. There are few factories that are able to manufacture vaccines, but they are doing it at the tail end, which is getting a finished product, and then you package it and you label it and all that. So that is the argument. But having said that, I think it's quite fascinating looking at the sort of the world wanting its cake and eating it at the same time, because if there's an acknowledgement that for each country it's difficult to deprive its population what it needs, if you need boosters, now there are children who are being added to the vaccine pool, the vaccination pool. If then it's clear that the supply is not enough. So it's like on one side, the supply is not enough, but whichever supply exists still has to be concentrated here before we can look at outside. And then sort of obstructing the few mechanisms that would make sure that supply is available everywhere. Because for me, the argument is not that don't do boosters because, don't do children because. Every single person needs a vaccine, whichever vaccine they need. So it shouldn't be either or. It should be a focus on systems and mechanisms that make sure that the whole world has enough vaccines and that my family doesn't have to wait until next year or the year after to get a vaccine. So I think that's the challenge, that somehow we don't have our cake and eat it at the same time, because it's like the only mechanism which will allow enough vaccines to be accessible is if they can be manufactured in many more places than they're being manufactured now.
Yes.
Yes.
Could I jump in? I had my hand raised. I don't know if you
Sure. Yeah.
Yeah, I just wanted to support the last intervention, because I think it's the issue of time frame is crucially important here. I mean, the house is still very much on fire. We are not through the pandemic, and while we all recognize that local production and tech transfer for vaccines, not just for vaccines but for therapeutics and treatments as well, is crucially important. And you will be aware that the ACT Accelerator itself is also actively engaged in this and supporting the first COVID mRNA technology hub in South Africa, and there are other initiatives underway. This is a medium-term solution, because getting that production capacity up online, doing the training, and as Catherine had said, in many instances, this kind of production capacity hasn't existed before. So getting it up to ready and running takes time. What we need to keep in mind is that the house being on fire, we have a supply issue. And right now the focus, perhaps in parallel, look at the local production and moving that out as quickly as we can for today, but also for the future. But we really need to look at how do we make sure that the available supply that we have is going to where it's most needed. And that is de-obstacling these very complex issues that were raised around how do you free up delivery schedules, how do you get the manufacturers on board in terms of releasing for the donations, all these things. But we have a supply out there and we could be diverting it better. And that's where we really need to be focusing urgently now, at the same time as working on these broader, longer term local production issues, which are also crucially important.
Thank you, Michaela. I'd like to turn to Sam. Malawi is considered a least developed country and therefore doesn't have to accept patents on pharmaceuticals until 2034. Now, Catherine raised the issue that there might not be the capacity at the moment, but the capacity could also be built up. What do you see, as sort of, do you see that as an opportunity for Malawi to invest in a local production site for pharmaceuticals?
Thanks, Catherine, for that. So, an important point for the issues around the intellectual property and local production of vaccines and therapeutics is that even with the best intentions beforehand, for example, with the COVAX initiative, Africa has not been served well by the Western and high-income countries during this period. So really, it is important to note that less reliance on donations of vaccines and medications by developing local production capacity will therefore be important. And so as Catherine was mentioning, if you go into countries including Malawi, you may not see that there would be capacity for the production now, as you have already said. But I think what would be important is that you have satellites or packets of sites within the region that can be able to do local production. In that case, because of the capital investment which is there, and because of the demand that will be created by different countries, the expectation is that the costs should be lower compared to what we get if we are not only relying on donations. The experience with more with the HIV program, and that's where done more work over there. The experience with ARVs has shown that intellectual property obstructions can be overcome in international crisis if there is a political commitment. So if there's a political commitment, both in the North and South, this actually can be overcome. Another point is that the local production of vaccines may remove also some of the fears that vaccines are tools from Western countries. For example, there have been issues to make people in Africa infertile and other theories which go along with misconceptions and may increase acceptability of vaccines in our communities. So in this case, I would say, look at the regional areas that could be able to be developed, technology transfer from the north to the south into the region, and then the regional countries, partners can be able to now tap into that. The other component is, I think you mentioned about the bilateral agreements when you're starting Astrid. The other component is that with the bilateral agreements, for example, once you have the vaccines produced locally, and also to make sure that the funds which are given by institutions can be able to be used to buy the vaccines that are produced locally. Because I think there have been some issues before, for example, even in the early days for HIV drugs. So I think that's what I would say for now. Over to you, Astrid.
Thank you. Yes, and we've seen that, especially Africa in the HIV epidemic has relied heavily on Indian generics. Yeah, and so we saw between April and September now for the COVID-19 drugs, India needed to stock up or its own supplies. It needed to provide enough medicine for its own country, and therefore could not really export much. Malay, can I return back to you? Bangladesh has a viable local pharma industry. How can that be used maybe to compensate some of the losses that we've seen, when India had to focus on itself? How do you assess that?
Yeah, thanks, Astrid. Yeah, I think that like Bangladesh, as you already mentioned, that Bangladesh has local production capacity. And some pharmaceutical companies already have, like at least one pharmaceutical company has already an agreement with Chinese Beijing Institute for Biological Products to produce Sinopharm vaccine locally. But the local production has not started yet. So, of course, like I agree with the idea of local production capacity or strengthening local production capacity. At the same time, I also agree with what Michael has already mentioned, that like we also need to invest in improving local production capacity for vaccines and other goods. But at the same time, I also would like to mention that it may not be necessary for every country in the world to invest in production capacity, because what we need ultimately is vaccines at a lower cost. So, for example, if we think about Global Alliance Gavi initiative. Through Gavi, we are getting vaccines for like polio vaccines, measles vaccine, other kinds of vaccines. So if we have a global supply chain that ensures, production and also supply, in every country of the world, responding to the need of those countries. So there may not be necessary or necessity to invest in local production for all the countries. That's my point to make. The other issue is about like this patent waiver. So in my opinion, when I take a look at the present situation and think about like the days, like one year back. So we must like congratulate the scientists all over the world who spend their time, also like pharmaceutical companies who invested, the governments took political decision, invested, like gave the pharmaceuticals company money to produce these vaccines, and also like to invent and produce these vaccines. And this is like, we are in a situation that within 1 year time, within 1 year of epidemic, we have so many vaccines available. And like even country like Bangladesh is also investing in vaccine invention, like one company named Globe Biotech. So it has also done preclinical trial, and 2 of their vaccines have already been listed in WHO vaccine trackers. So so we must congratulate the scientists and others involved with these vaccines. So in summary, I would say that it's a very good idea to improve or strengthen local capacity for vaccines, but also like make these vaccines as public good, so that this patent rights and other issues do not jeopardize production and accessibility and availability of vaccines. There must be equity for vaccines, like all the countries in need of vaccines, they must get these vaccines. But at the same time, I would like to reiterate that like all the countries may not heavily invest in improving production capacity. Thank you.
Thank you, Malay, and thanks for also addressing the waiver question, which I think was also a request from someone in the chat, to hear from you how you assess that. Can we now move on, in view of the time, to from vaccines and access to vaccines to Michaela, you mentioned the ACT-A accelerator is more than just access to vaccines. It's also access to diagnostics, to therapeutics, and health system strengthening. And how do you think we have fared in those other realms?
I'm not sure I can comment on how we fared in the other realms, other than to say that as you'll see, and as it was already pointed out, the inequity in access to testing is also a huge concern, not only in terms of testing testing levels in general, but also in terms of the testing needed for the genomic sequencing capacity and our overall understanding and monitoring of the evolution of the virus itself. So this is another area. And as you will know, many of you as well, we've had issues with access to treatments, and oxygen, lack of oxygen has been a huge, huge issue globally. So, I think from the perspective of the ACT Accelerator, and as I said, the framing is that we need the full package of tools. It's not just about vaccines. We need tests. Tests are needed to inform where we deploy measures, where we use our public health and social measures in the most effective way. We need testing to inform what treatments are the right treatments. And obviously we need treatments because we still have people that are affected by COVID, and we'll continue to need that. And as I said earlier, we need to make sure that the implementation of all these tools, of all these countermeasures, is done in a safe way. And therefore we need to protect the health workers that are delivering these things. And you will also be aware that another big part of what the ACT Accelerator is focusing on is, as you just said, it's the point where all of these pieces come together in the health systems, and making sure that the health systems can make the best use of it. So making sure that it's safe, but also making sure that any kind of critical bottlenecks related to their use are addressed. That is also a core part of what the ACT Accelerator is focusing on.
Thanks, Michaela. Can I just interrupt here, because Carl Lauterbach just said you have to leave. Could I ask you one last question?
Surely.
Is that thank you. We just heard, that we also need, access to tests. We need to build up health systems. Now, Germany has put more than its fair share on the vaccines. Less money, in diagnostics and health system strengthening. Again, I know you can't talk about details yet from your coalition talks, but what is the intention of the new government? Is that going to be rectified? What is your vision?
Well, clearly we have to be better prepared for such a pandemic, and there will be more pandemics to come. next time. So we are thinking about what type of preparedness in terms of, let's say, vaccine management, vaccine production, vaccine invention, gear, and testing should be made available to the population at any given time, and in what way we can support poorer countries to be in a similar situation, a similar preparedness that we know from modeling and also economic modeling. And here I fully agree with what Dr. Stolpe said before, that from the perspective of an economic view, preparedness, vaccines, vaccine investigation, vaccine development, all of this is, let's say, from a cost-effective perspective, a very good investment. It is a pandemic that is important to prevent. It is a pandemic that is very difficult to contain if it is there. It is a pandemic with all that follows from this pandemic, which is economically a catastrophe. So therefore we will be, I hope at least, we will be in a much better position to, let's say, defend ourselves against the pandemic, but also in a position that we help international organizations to be better prepared, and that we will do through EU collaborations, but also bilaterally.
Thank you very much, and all the best for the ongoing coalition negotiations.
Thank you so much for the opportunity, and also for having me on the panel. I learned a lot. Thank you so much. Bye-bye.
Thank you. Bye. Can I continue with you, Dr. Stolpe, where it's just the pictures have changed with a person leaving. We've seen that the prices can vary from one country to the next, and that there's also little transparency in the pricing of vaccine. And the same is true for diagnostics and therapeutics. Often we don't really know what's in those bilateral contracts. From an economic point of view, what would need to happen to work towards more equity in the access to diagnostic and therapeutic services, particularly for low-income countries?
My proposal would be to also use the patent buyouts to for a fund like COVAX to acquire the patents and then offer free production licenses to any qualified producer in any country that has such qualified producer. But I also want to emphasize the patent buyouts are different from the patent waivers also because the patent buyouts generate incentives for the current owners of these technologies to transfer the technology that is necessary to make it a success, because in the patent buyouts, the current owners can earn more money. They can make a greater financial profit if they include contracts that ensure that the tacit knowledge, the technical, the managerial know-how needs to be transferred. So in addition to the testing that has been mentioned, I also want to emphasize that we need access to genome sequencing in all countries, because the mutations, the escape mutations, are so much part of the threat that SARS-CoV-2 continues to pose to the world economy. And if we are not surveying properly what mutations emerge in areas of the world where the viral spread is rampant, then we are not doing our job efficiently, right? So that's one point I would emphasize.
Thank you. Sam, can I turn to you now? There's all the various instruments with the ACT accelerator, the TRIPS waiver, the technology access pool. Some have called for, a further strengthening of the international health regulations, or maybe a different treaty. What do you think would work best to improve the situation in Malawi?
So thanks, Astrid, actually. I think we've talked more about issue. You talked about the waiver, and then you talked about issues related to, in this case, for example, I think what Dr. Stokes is talking about, buying the patent to make sure that all the commodities are available. There have been several challenges which have happened in developing countries, including Malawi. For example, in this case, the availability of the diagnostics, so either rapid test or the PCR in this case. So even if people wanted to come for a test, but well, these are not available, and then also once they've been tested, what treatment options are available for those with severe disease. And so most of the issues related to now the personal protective wear for our healthcare workers to make sure that they feel confident in how they can manage the cases. So the major challenge being, for example, the oxygen supply, knowing that monopoly of available, the ones who are like producing the oxygen available, and this is like a life support, but very expensive, and not many facilities having the oxygen support available, and some of the plants that are available within the central hospitals not able to cope with the number of cases that have been available for admission. So I said, we need to make sure that we leverage, for example, some of the support has been leveraged in Malawi from the HIV care and treatment programs where the implementing partners have been supporting some of these based on the resources available. So I also think that when we look at health systems, for example, it means that we need to make sure that the COVID-19 epidemic can offer opportunities similar to the HIV epidemic to improve primary health care in low and middle income countries as an integrated system rather than adding a silo structure for COVID-19 care. Even though the latter may be the natural approach in a crisis, but I think now having done 3 waves, for example, for Malawi, as we're moving forward, we know that COVID is here to stay. We just need to make sure that we see on what we think can be integrated within the system and then improve the health system to make sure that the general health is also managed, including TB, because the symptoms are the same along with COVID-19. So that's, I think, what I would say in terms of leveraging whatever resources are available to make sure that the health system is robust enough and also the healthcare workers are supported enough to manage the epidemic. Over to Astrid.
Mm-hmm. Thank you very much. Catherine, can I turn to you? Would your view tally with Sam's, or do you have a slightly different view as to what might be needed in Kenya to really improve the situation?
I think I have a completely different view, and because almost everything we're talking about, I would look at it as software, as hardware that's needed to deal with pandemics. And my view would be that we need a different software in how the world operates. I think for me, that's what's fundamental. And that software could be sort of ceding a bit of power, because I think in the current situation, what we have is that the need to maintain power, whether it is economic power, financial power, political power, has superseded everything. We want to maintain all the power relations as they exist, even in the pandemic, which might be the first one. This might go on for the next 5 years. It's not going to be the last one. There are many other crises that are coming, but as a race, as people, we still want to keep the same software of broken power systems. I think for me, that's the fundamental thing. Because if those power systems are broken, then we'll have all the tests we want, I think. And Michael has lots of ideas about how this can happen, but there's still something. Somebody somewhere is making a calculation and think about how many billions of revenue they're going to lose. And so maintaining that supremacy of financial clouds then becomes the biggest issue. So I think what we need is a different software in how we relate as human beings. Because other than that, it will be COVID, it will be HIV, it will be health systems, it will be climate change, it will be many other things, and we'll still be, tinkering on the edges with hardware. that doesn't serve all of humanity.
Thank you very much, Catherine. It's already 5 o'clock, and Michaela Pfeiffer just said she has to run off to the next meeting. If you're still with us, I just like all of the panelists, thank you very much for all of your contributions. Maybe you can just all end up with one last sentence. In order to reach global COVID-19 control, we need to. How would you finish the sentence, Michaela, if you're still there?
You just grabbed me. I think we need to get every country to the minimum coverage targets needed. I think this equity issue is at the core of getting us into the next phase. We've talked a lot about some of the lessons that we're learning about what we need to do differently next time, and I think that's super crucial. But really, we need to make sure that all countries have access to the minimum of these tools needed to ensure their national public health objectives are met, and to bring an end to this acute phase of the crisis. So equity is the overriding sentence.
Thank you, Michaela, and thanks for being on the panel. Dr. Stolpe, how would you finish the sentence? To reach COVID-19 control, what would need to be done?
I agree that we need to prioritize equal access to the vaccines and other tools that have been developed for all people, wherever they may live. And at the same time, we need to maintain also the financial incentives for those that have the capacity to innovate, develop new vaccines that may be needed against escape mutations, but also against future pandemics. And therefore, it would be very critical if we short-sightedly sort of expropriated patent by means of waivers, because a much more effective tool, a much more effective way is available, known as patent buyouts, where financial incentives are maintained, innovation is rewarded, and access is accelerated for all people in this world. Thank you.
Thank you. I wished we had another hour to discuss those issues, but unfortunately time is running out. Malay, how would you finish the sentence?
Well, I mean, in summary, we need a science-based strategy. And as Michael mentioned, genetic surveillance for not only for COVID-19, for other emerging threats, vaccine and drug equity already mentioned by a lot of us. At the same time, what we didn't discuss a lot is public health measures. These clinical health measures, diagnostic tests, vaccines, but at the same time, we must not forget the non-pharmaceutical measures that are also important, like social distancing, mask wearing, so all those things. And there can be public health laws to enforce those measures at the same time. And of course, we must have a global alert and rapid response system, international collaboration. And for this rapid response, there can be some fund allocated for this, so that like we don't need to mobilize fund like through different initiatives, and of course like ongoing research through public and private initiatives. So and address the need for shortage of health workers and health system resilience at the same time. And there can be like pool of health workers who are trained but ready, and also like some common people who are trained on some issues and then ready, like a war-like situation. In many countries, they are like military training, so something like health system or health care provision training for them. So in summary, this can be done. Thank you.
Thank you. I think there was a little bit more than one sentence. So, Sam and Catherine will end up with you. In one sentence, what is the most important thing to get control of COVID-19 worldwide?
So thanks, Astrid. So I think science, there's been a breakthrough on science on looking at what are the issues around the universal prevention, issues around treatment, and then issues around vaccine. So I think my expectation would be that there will be a full political commitment both in the north and in the south to make sure that these are implemented. So we need to have equal access to the three components that I highlighted to make sure that we can curb this epidemic. So I think with that, I'm sure we should be able to have a control and any key messaging to the rest of the general public so that they know on what we want to do rather than to just take them off guard. So that's what I would say for now, but we are screen.
Thank you. Catherine, you already talked about the software. So how would you get the software into this last sentence?
In order to stop COVID and future pandemics, I would say we need to redefine what's most important to us as human beings and define, I think, a new way of relationships that are grounded in equity and justice. Because the world has enough resources to go around. It's just those software that's missing.
Thank you. That's a wonderful final sentence. Thank you very much for being on the panel, for sharing your expertise. I wished we had another hour to go into more detail, but it was very interesting to listen to you, and all the best to everyone. And I now hand over, I think, Florian, are you taking the last session? You moderating the last session?
Yes, I guess so. There, of course, we will be more of us. Sorry, I get the different view. So for all those on the panel who are still around, it was fascinating listening to you. I think, as Karl Lauterbach said, I also learned a lot. And honestly, I like both aspects, the hardware aspect that Sam was mentioning, and we need for the burning house that Michaela was saying. But indeed, I think the new normality, I don't think that this crisis will go away with our usual normal. We really have to appreciate that this is a crisis. Remember what Remco showed this morning, the waves, whether it's the COVID or whether it's the economic recuperations, more poverty and climate change threatening the globe. I think it is another moment to say we have to change our mindsets. And there is only one globe, and we have seen that in the discussion, to the best of my understanding, that yes, global solidarity is easy to ask. Pragmatically, Michael Stolpe pointed out we need to keep up the incentives for people who are innovators. That's very much of important, but also we need to use this buzzword, we need to move away from charity and really decolonize the global health and come to a true global solidarity. This might be wishful thinking, but I think it's high time to act on that. So I was very much impressed by this by this final panel. And Astrid, I have to say as well that you did a great job in this not easy task to do justice to a high-profile panel and to give everyone the chance to talk. I think you did a great job, so thank you for that as well. Before I move on, maybe I see Eric from Geneva there. Maybe I hand over to you for now.
So thank you. I think it's time now to make a kind of overview of all this today. That was very interesting. I don't know how you want to proceed, Florian.
Just do it from your side. I have started with the panel now. Maybe since you were also in the in the workshops. Maybe just try to start with a kind of summary from your perspective.
No, thanks again. I think it was quite challenging to organize this first Global Health Academy. So thanks to all the team of Heidelberg, the team who organize, and all the panelists who come also in this different session and workshop. And also I think that we need to thank the technical team, because it's really challenging to organize so many discussions. And sometimes the workshop, it was 4 discussions in parallel. So you could have a lot of different bugs, and even if we have 1 or 2 little bugs, I think that all the things was really well done and well appreciated. I remember you that the participant came from 18 different countries. And some of these countries sometimes have no easy access to internet, but at the end we succeed to do that. So it was really already a good step to do. I follow also a lot of workshop, and I think that this workshop go really in the spirit of this Global Health Academy, where we really want to facilitate the contact between the speaker and the student. So really, I think it was well appreciated. It was my first comment for the moment.
Yeah, thank you for that summary. And it's of course, yeah, it seems like a ritual, but I do mean it. I was naive in thinking that organizing a virtual conference was maybe easier than to have a face-to-face one, which I had the pleasure to do. But so I have to say thank you. I didn't even know that we had such a wonderful institution in our university. So whoever is there, I just name Christiane more now, who was our key person, but definitely all your colleagues, thank you very much. Then all the people who organized workshops, they did it with nobody got any incentive other than to have maybe a good international audience, which may be enough for some people. So really, really a big thank you for all the people who did the workshops. And we will look at this, and I will also, for those who are still listening, please, there will be an email with an evaluation questionnaire. Please do us the favor and fill it in and send it back. It's very helpful for us. We learn a lot in science and in the COVID pandemic management, but we also learn how to conduct such conferences. So I would really ask you to assist us with that. Then, of course, looking back, we had all the speakers. Yesterday, Lisa Foreman set the stage with the equity and human rights aspect. And we also had the country contributions with those people who presented their posters. Also, this one is an interactive part. We would have thought maybe we got more, but it was a very good contribution. And then today we looked at the medical part of the pandemic and the global public health measures. There is so much to see and to learn. And as we know, managing this pandemic is an ongoing learning experience. So, and that was clear in the final panel. And it is not just, there is also a conflict of interests. Yeah, we should not say, wonderful, everybody wants to do and work for the good, but we have great global commitments, for example, in the ACTE with the 70% coverage globally. So there is a lot to do to reach that. And we do hope that you carry on the ideas and stimulations from this conference in your local and regional networks, and so that the discussion continues. Lisa, are there any questions or comments from participants, or are we through? And I don't know whether...
No questions.
Okay. And I don't see Volker. So in winding up, then I would say we have been a wonderful team with Geneva, Jelena and Eric, and Claudia Beiersmann, and Volker and myself here at the Heidelberg site. And Lisa, thank you for your support. And with that, I would call it a day.